the last lecture. Da-da-da-da-da-da. Today we're going to finish up the hematology section, cover a little bit about hematologic problems that are specific to children. Excuse me, I've got a little allergy glop going, but I think I can make it through this one okay. So we're looking at problems with white blood cells, starting off here. The last lecture we spent a lot of time with anemias and things that were problems with erythrocytes, but here we're going to have white blood cells, too many, too few, or they don't work right. So quantitative disorders, we either have overabundance, it may be on purpose, it may be a good thing or not, or we don't have enough of them. Qualitative disorders means that they're not working right. Could be because they've been damaged, could be because they're created improperly, or they may have cancer. Start off with too many leukocytes. So this is overall. Usually you'll measure the number of neutrophils because that's what you have the most of. But here you can see there's an awful lot of white blood cells. Normally in a panel this size you just have one or two. So there's a lot. Normally that means that you have an infection. When you get an infection, the immune system sends out cytokines, sends out signals. The bone marrow suddenly releases a whole bunch of additional white blood cells to help fight it. So cytosis means too many. Also, philia means a lot. So neutrophilia is too many. So there are a couple of terms for overabundance. Penia always means too few. So leukopenia, you don't have enough for one reason or another. So looking at granulocytosis, neutrophilia, again, granulocytes, neutrophils, eosinophils, basophils, we can look at them separately, or we can look at an overabundance kind of, all of them, but generally you're looking at neutrophils because that's what you mostly have. And here's a bunch of them. Here we have a bunch of neutrophils. Once again, too many of them often means that you have an infection. Now there's another way to determine whether it's an infection, an acute infection that's causing a release of a lot of neutrophils right now, or if maybe you just are making too many of them and you've had too many for a while. When neutrophils sit around in your bloodstream, float around for a while, they become fully mature. They have this granular appearance, lots of little dots in them. But when they're first released, all these little dots are kind of conglomerated into one spot in the cell. So an immature neutrophil looks more like this. A mature one looks more like that. And if you do a blood count, if you do a neutrophil count, and a disproportionate number of them are new or immature, that means you have an acute infection. You're releasing a whole bunch of new neutrophils into the bloodstream. This is called a left shift because the proportion of immature neutrophils is going to be higher than the mature ones. Otherwise, if they'd all been in your system for a while, most of them would be mature and you would shift back to the right. We can see some that look quite granular. We can see others that look more like a blob. These are less mature than this one, for instance. Neutropenia is when you don't have enough of them. Couple of reasons. If you have a really prolonged infection, you can use up the ones that are there. So they either have already gone into the tissue and turned into pus and died fighting, or they are sequestered, they're stuck to the vessel walls, in which case they don't show up in a blood test because they're not floating around in the blood. You may not be making as many because the disease may affect the bone marrow, the cells in the bone marrow that are making them. Granulocytopenia, meaning not enough of them, You can have, a decrease, again, of just neutrophils, or they can be all the granulocytes. If you have immune mechanisms, you're fighting your own tissues. A problem with stimulation of hematopoiesis. You have a problem with your bone marrow, or it has a problem responding to cytokines or whatever signaling molecules might be there. Chemotherapy kills bone marrow, and therefore you might have to take some out and put it back in after you have chemotherapy. And so does radiation therapy. If you have bone cancer and you radiate it, you're going to kill a lot of the bone marrow, a lot of the hematopoietic cells in there. Eosinophilia means a whole lot of eosinophils. Allergies, allergies, allergies. You have an allergic response to something. These are all eosinophils. They have penetrated into this tissue. Now, this is under a microscope slide, so if it's in the blood, they're being released into the blood, but once they get into the blood, they're going to try to find a place to go, and they may disappear again. So you have to be judgmental about where these eosinophils are. Anaphylaxis, a huge immune overreaction, would cause you to produce a ton of eosinophils and move them into the tissues, causing all kinds of allergic response. It may be an appropriate allergic response. You may have something in your system that you should be responding to. And they respond to parasites. So if you have a parasitic invasion, you're going to make more of them, especially acutely, and you'll move more of them into the tissues to fight the parasites. Eosinopenia, not enough of them. First of all, if they have all migrated to the site, they're not in the blood anymore, so that's one possibility. Another is you have had something that lowers your immune system. You have an overproduction of cortisol. That lowers your immune response. Burns, mental stress, things like this, autoimmune diseases that lower your ability to have an allergic response may reduce the number of eosinophils. Monocytes are less indicative of what's going on. They don't suddenly go up when you have an infection. They do a little bit. It kind of follows the neutrophils. Monocytes, though, are more likely to aggregate in places like cardiac blood vessels long term, and they move across and try to kill the bad guys across the vascular wall into the tissues. But monocytosis, generally, if you have an inflammatory problem, you'll probably have more of those. Monocytopenia is not exactly described. And your lymphocytes, of course, in the lymphatic system, your B and T and natural killer type cells, they're going to go up if you have a response that stimulates them, which is more likely to be a viral type infection, because with a virus, you force your B cells to mature to plasma cells, make antibodies to fight against the virus, and so you'll have this signaling from the periphery saying that we have a viral infection going on. You increase the number of B cells that are in the lymphatic system and also now releasing into the bloodstream to fight there. So viral infections, especially Epstein-Barr, we're going to see Epstein-Barr all the time. Lymphocytopenia, not enough of them. They can be damaged. You can have a lymphatic lymphoma, lymphatic cancer, immune deficiencies, or if the virus is actually, especially Epstein-Barr, which actually gloms onto the B cells, actually causes destruction of those B cells. Infectious mononucleosis, good example of Epstein-Barr. EBV, the kissing disease, because it's transmitted by body fluids, and you can transmit it with saliva, which fortunately you can't with HIV. But the beta cells actually have a receptor site. When Epstein-Barr shows up, it actually sticks onto the B cell, stimulates the B cell to make antibodies theoretically, but the virus itself then can infect and attack the B cells. Serious inflammation, really badly inflamed, infected tonsils, and hemorrhagic sclera. Some others that will do this, other viral infections, a cytomegalovirus, which we see more in the lungs, hepatitis, liver, viral hepatitis, influenzas, a flu virus, HIV virus. Mononucleosis, fever, sore throat, you can see why. Swollen lymph nodes in the neck. You generally treat the symptoms and let it resolve on its own. It takes a while. People are sick with mono for a while, and they usually kind of sequester them because they can pass it on to somebody else, especially if they go around kissing everybody. Usually heals on its own, but you know, a couple of % of people have really serious complications, including rupture of the spleen. So it really should be treated and monitored if somebody has it. Leukemias are blood cancers. They can be cancers of the blood cells themselves, or they can be cancers of the myelogenous tissue, myelo meaning center, so that bone marrow. Bone marrow cancer, and it produces then leukemic cells, which are distorted, improper types of cells, cancerous in their own way, immortal perhaps, so that they can divide and divide and divide without limit. Pancytopenia might be a result because the bone marrow is diseased. It's being crowded out by this overproduction of cancerous type cells, and then it can't make enough plain old red blood cells, and you wind up with anemia. Acute leukemia, again, the greatest number of cells you'll see are immature, brand new produced cells, because you're turning out a new supply of cells, an oversupply of these immature cancerous type leukemia cells. Chronic leukemia, they're more mature cells. They don't work right. You can't expect leukemic cells to fight for you in the case of an infection. So leukemias either come from the blood cells themselves being cancerous or from the bone marrow. So they're either lymphocytic, lymph cell leukemia, acute or chronic, or they're myelogenous, created by the bone marrow, acute or chronic, and the acronyms for them. Leukemia, anemia, can't make enough good red blood cells. Bleeding, bruising, you can't make enough good functioning thrombocytes. Petechia, the little tiny spots. Ecchymosis, where you're getting ruptures under the skin that produce purple spots that have nothing to do with bruising, with blows. Thrombosis, creation of blood clots and destruction of the clotting mechanism or interference with it. Hemorrhage, so too much clotting, not enough clotting. Disseminated intravascular coagulation we'll look at in a minute. That's a pretty serious condition that can come from this. infection because your immune system isn't working right, enlarged lymph nodes, enlarged other lymphatic tissue like the spleen. And at least one kind of leukemia has been identified as a genetic disorder born with this abnormal gene called the Philadelphia gene. It's a translocation, actually. The gene is put in the wrong place and predisposes or even causes you to have a myelogenous leukemia. Be nice if they could find a genetic cause for a lot of other cancers. They're working on it. So if you have either a infection, a viral infection that affects all those B cells, a leukemia, a cancer, you're going to have lymph gland disease. Lymphadenopathy means a lymph gland disease. Your lymph nodes will swell up. Could be cancer, could be not. Could be local. If you have an infection in one area, you'll have those lymph nodes swell. You know, if you have mono, your neck lymph nodes are likely to swell, or it could be widespread like in this guy. Here's some malignant lymphomas. They're doing a scan and looking at lymph nodes and seeing where they're especially drawing in the extra contrast medium, extra blood flow, because cancerous tissue tends to increase blood flow to itself. And two major categories of lymphomas are described. Hodgkin lymphoma was one of the first ones that was discovered by a guy named Hodgkin, and so named it after himself. And so we think of this as being one disease, and a lot of people think of non-Hodgkin lymphoma as being the other one, but it's everything that isn't Hodgkin. You know, everything in the world is either a squirrel or it's not. I mean, most things aren't squirrels, but it's either or. So either you're you have Hodgkin, or you have one of the other types, of which there are several. The Hodgkin lymphoma is one of the diagnostic tools is to look for these Reed-Sternberg cells. They're overgrown, out of control B cells that split, but then they can't completely separate. And they look like a little owl. You see these Reed-Sternberg cells around. And you can have a couple of those in non-Hodgkins. But if you don't have them, you don't have Hodgkin. I mean, Hodgkin for sure will have these, and maybe even a predominance of the bad cells will be of this type. With Hodgkin, adenopathy, swollen, diseased lymph nodes, masses in the abdomen, masses in the mediastinum, around the heart, large spleen, overgrown spleen, weight loss, itching, and every kind of problem you can imagine with your types of blood cells, including an elevated sedimentation rate, which means that when you put your blood in a thing, the red blood cells settle out of it more quickly than they should. Hodgkin lymphoma, even though it's a system-wide disease, the signs and symptoms occur in the spots of the greatest number of lymph nodes. The neck, the armpits, the groin. Non-Hodgkins then are several other lymphomas, and they are best described nowadays by the type of cell that becomes cancerous. You can have a T cell lymphoma, a B cell lymphoma, a natural killer cell lymphoma, and each one then has a sort of different signs and symptoms, etiology, sort of different treatment, linked to chromosomal translocations like the Philadelphia, viral and bacterial infections causing inflammation that causes the cells to cancerify, immunodeficiencies where your immune system can't fight off the normal number of cancer cells that it can normally control. See, here we have a bunch of abnormal cells, an increase in the number of cells. A lot of them look like immature type cells. And maybe there's a Reed-Sternberg. That's not exactly, because those have actually separated. So it can have some, but it's likely to have a predominance of the other kind. Some of the pro-oncogenes, that epigenetics changing, affecting pro-oncogenes, turning them into oncogenes, removing some of the tumor necrosis factor, the tumor suppressors, and thus allowing cells to become immortal so that they can replicate forever. Another non-Hodgkin lymphoma that we'll mention again with kids is Burkitt, which is almost specific to the jaw and face. It's a very aggressive, very fast-growing non-Hodgkin lymphoma that likes to affect kids. Epstein-Barr virus, yet again. Okay, moving away from the actual leukemias, now we're moving into the bone marrow, which is, related, of course. Multiple myeloma, that means tumor of the bone marrow. And this, this is not the kind of bone that has the greatest amount of red blood cell production, or blood cell production. Those are the flat bones. But you still have bone marrow. You have yellow marrow down in here, and you have some red marrow up in the trabecular spongy bone up here, and it infiltrates, grows throughout the bone, causes the bone to become really brittle and break easy, causes a destruction of the compact bone on the outside, and all that release of calcium gives you hypercalcemia. And in many of these lymphatic type of problems, you'll get an enlarged spleen. The spleen is lymphatic type tissue. It filters a lot of blood cells. You can have damaging and scarring and blocking of the outflow vessels and cause it to swell up because it keeps getting pumped in and it can't release. You can also have so many of these extra damaged large cells that they clog all of the little tubes that are in the spleen. The liver too, and can wind up with an enlargement. Here, the spleen is bigger than the liver. It's supposed to be like, that big, not this big. Platelet disorders are either going to make you clot too much or not clot enough. Bleeding disorders then. And thrombocytopenia, you're more likely to have too few than too many. Thrombocytopenia means you drop below 150,000 per cubic millimeter. Below that, anything that bumps you will make you bruise. Below that, you'll just start bleeding and getting purple spots everywhere. hypersplenism, overgrowth of the spleen, autoimmune diseases where you're attacking your own thrombocytes. You can actually have antibodies, make antibodies that inappropriately attach themselves to your thrombocytes and cause them to become non-functional. Either it makes your other immune cells eat them, or they just can't work because they have an antibody stuck onto them. Idiopathic thrombocytopenia, purpura, causing bruising. So this is genetic or something, not specifically known, but it's kind of autoimmune. Your own immune cells attack the thrombocytes, produce antibodies that attach to them. In kids, this is common after a viral infection that causes an overproduction of immune cells and an overactivity of immune cells to begin with. Thrombocythemia means too many of them. If you have too many thrombocytes, you're going to form clots all the time. And little clots will block blood vessels. They won't let blood flow through. Can cause strokes, can cause deep vein thrombosis, can cause any number of problems of the microvascular especially. Platelet counts over 600,000. So there's a pretty wide normal range. Below 150 and over 6 are outside the normal range. And platelets can simply stop working as well as they should. Either they are unable to activate and become spiky and stick together. They have a problem with some part of the membrane makeup, or von Willebrand factor, which is released to help cause the aggregation and binding and platelet plug formation. And you can get spotting on your skin, you can get bruising on your skin, bleeding gums, spontaneous bruising. Another thing that can cause spontaneous bruising is a vitamin K deficiency. Your clotting factors are many, and 6 of them require vitamin K to function properly. So vitamin K deficiency means for sure you're not going to clot properly. So even just walking around, you break little tiny micro blood vessels and they don't stop bleeding, and the bottom of your feet get covered with essentially bruises, bloody nose. More common in kids than later in life. Kids' immune systems, kids' clotting systems, and so forth are not developed fully. When babies are born, they give them a vitamin K shot, whether they need it or not, just to be sure that they're not deficient. Here's our disseminated intravascular coagulation, DIC, and this can be, a problem with autoimmune attack on your own blood vessels. It can be initiated by viral infections and the like. What happens is your clotting mechanism gets out of control, overstimulated, and remember, there are 2 parts to the clotting. You make clots and you make TPA and break them down. So you're constantly cycling through clotting, breaking down, clotting, breaking down. It results in damage to the vascular wall, hemorrhage, and clot. A cycle of hemorrhaging and clotting that destroys small blood vessels and can cause a loss of blood flow to especially your extremities. Kind of like having diabetic loss of blood flow. Here's somebody, disseminated intravascular coagulation. Looks like they're probably going to lose their fingers. It can be fatal. How do you assess whether your blood can clot properly or not? Couple of ways. You can just take some blood out and expose it to air and see how fast it clots, because air stimulates it to form clots. So, you know, you can see if that's about the right amount of time. That's not a perfect example, though, because when you're inside and not exposed to air, you're required to combine extrinsic and intrinsic clotting factors together to form clotting. So if you want to be a little more specific, I kind of mentioned this once before, you can do a prothrombin time test or a thrombin time test. Prothrombin, you add tissue factor and it tells you how quickly you can make prothrombin, which is the first of the substances to combine in this intrinsic pathway all together here, or combined pathway, I should say, the extrinsic and intrinsic. Extrinsic means it's coming from the blood, and if you can produce the prothrombin, then it will combine with the intrinsic pathway into this common pathway that gives you your final clot. So if there's a delay between adding tissue factor and getting prothrombin, then you have a problem out in the blood. Or if you add thrombin and there's a delay in getting your final clot, then it's an intrinsic pathway problem. Intrinsic common pathways. Anything other than the extrinsic pathway. So some things very common to children, and most of these things we've seen before with adults, but we want to talk about how they affect kids and the ones that are most likely to be seen in kids. Iron deficiency anemia, pretty common in kids. Inability to use iron because of immaturity. Not enough iron intake, you know, especially in a kid who's not breastfeeding, or internal bleeding. So not enough iron to make the balance of the replacement blood cells you need. And the kid, just like anybody with anemia, gets weak, irritable, lacks energy. Hemolytic anemia means you're breaking apart your red blood cells, and this potentially lethal condition is generally caused by a Rh positive baby being inside an Rh negative mother who responds to its Rh positivity. That means it has an Rh factor that the mom doesn't have. The mother will produce antibodies, and her immune system will try to kill her own child. Usually it's the second Rh positive baby in an Rh negative mom, because their blood systems don't intermingle during gestation, but at childbirth there's an intermingling. The mom detects the Rh factor and makes antibodies against it because it's not a factor that she already has. If she's Rh positive, everything is cool. The baby can be Rh positive or negative. It doesn't matter. It doesn't have something that she doesn't have. But if she's Rh negative and it has the Rh factor, she'll fight against it. And what happens is her immune system will attack these red blood cells and cause them to agglutinate. They'll all stick together. So there won't be enough useful free-flowing red blood cells out there. It becomes anemic, seriously anemic, but also those blobs of agglutinated blood cells can't fit through capillaries, and they clog up capillaries and cause a lot of lack of blood flow, lack of oxygen getting to the tissues. Sometimes it's an incompatibility between blood types. You know, the baby's a type A, mom's a type O, so mom doesn't have the type A, so she'll fight against it too. But it's not as common, it's not as usual for the mom to respond that way to a different blood type as it is to that Rh factor. You can take medications to prevent your response to that. So a blood test to find out if you're Rh negative is important. If you find out early in life that you're like, I'm B positive, okay? Well, if I were a woman and was going to have a baby, I wouldn't have to worry about it. I already have the Rh factor. So if the baby has it, I'm not going to fight it. It's not going to be a problem. It's only if you find out you don't have that factor that you could have this problem. Some inherited disorders. The first is one we've talked about quite a bit, sickle cell disease, sickle cell anemia, they usually call it, because the sickled cells don't work as real blood cells, and therefore you have not enough useful red blood cells. Plus, they block the entry into the capillaries and cause lack of blood flow, caused by the hemoglobin S, the hemoglobin sickle cell, and dehydration causes them to sickle. High altitude, low oxygen tends to cause them to sickle. Vaso-occlusive crisis, not enough red blood cells. Sequestration, where they're all sticking to the side of the blood cells. And they break apart easily too. Sickling of cells, virtually entirely people from African descent. We talked about that before. Congestive heart failure, damage to the heart muscle. Chronic ulcers, because you can't get blood flow to heal them, very much like a diabetic ulcer. Blindness, stroke, from lack of ability to move blood through capillaries. Another one that is kind of sort of like it, also an autosomal recessive disorder, so both your parents need to be carriers for you to suddenly have it, unless one of them has both genes and is, you know, heterozygous, and therefore they know they have this disease, in which case they probably shouldn't be having kids. Thalassemia is a disorder that causes the cells not to sickle, but to turn into little squares, little cubes. And the same thing, they won't go through red blood cells very well, and it will cause a similar problem with blood flow in the extremities. Thalassemias. But furthermore, it's a genetic disorder that has some other ramifications too. You have minor and major versions of it. Even the minor version can cause microcephaly, retardation, changes in the facial structure. And the major version is generally fatal. Hemophilias are bleeding disorders generally based on the fact that you're genetically lacking a clotting factor. Factor 8, hemophilia A, the most common one. Von Willebrand disease, you don't have von Willebrand factor, so you can't start the process with platelet aggregation and all that. A couple of other abnormalities, deficiencies in clotting factors. Antibody-mediated hemorrhagic disease, platelet destruction rate. Your autoimmune system attacks your platelets and kills them. We kind of talked about how that would work before. Happens in babies. Their immune systems are immature. They're not their responses aren't always appropriate to start with. In many cases, the kid gets a virus first. It activates the immune system, and the immune system is not specific enough and goes after the baby's thrombocytes, platelets. Most kids recover from it on their own. And leukemias are the most common cancers in kids. Most of them are cell-related, lymphocytic or lymphoblastic. The lymphoblasts are the creating cells, those fast, growing cells that, that babies have a tendency to have anyway. A smaller number are myelogenous within the bone marrow. Here we see a lot of these overgrown lymphatic cells, leukemic cells, and they've improved a lot. The 5-year survival rate, 80%. When I was growing up, a couple of kids I knew had leukemia. They didn't last very long. They weren't able to treat very well at that point. And 5-year survival rate doesn't mean they all drop dead at 5 years. It means that they're still going after 5 years. Kids tend to have non-Hodgkin lymphomas. Hodgkin lymphoma is pretty rare. They have a couple of different kinds of non-Hodgkins, Burkitt being an important one, the small cell Burkitt lymphoma that grows the big thing on the face. They can be initiated by viral infections, immune deficiencies, and the like. Kids' lymphomas tend to manifest more locally. Again, lymphomas are kind of system-wide diseases, but adults are more likely to get them in multiple sites, and a kid is at least likely to start out with a lymphoma that manifests itself in one of the, or maybe two of the sites. So that finishes up the hematologic system. It also finishes up the course. If you haven't already, I would strongly suggest you start going through some of your practice questions and early quizzes from the early part of the course. Start working on your preparation for the final exam. Don't wait until the last minute. I hope you've enjoyed the material in the course. I hope it makes you really successful in getting into the program you want and in doing well in your career in the medical field. Good luck on the final, and I hope to see you sometime.